This is where the ground breaks. What's never been done is what we do. It takes a city to change the world.
Good afternoon, and thank you all for joining us today. I'm Julie Kenville, and I'm CEO at UHN Foundation. I'm pleased to welcome you to today's United Behind the Scenes virtual conversation series. We host these meaningful conversations 4 times a year with leading experts from UHN to showcase the incredible advancements in discoveries and the latest cutting-edge medical breakthroughs happening each and every day in our hospitals. As a valued member of our community, we are thrilled to give you this exclusive behind-the-scenes visit with us. Now, UHN is Canada's #1 hospital. It's the #3 best hospital in the world, but it is also this wonderful distinction of being the top publicly funded hospital in the world. We're incredibly proud of this achievement, but we could not have achieved that without you, our generous community. Thank you so much for your generous support, which has allowed us to purchase equipment, to support top talent, to recruit and retain top talent. Thank you so much. Now, this month is Parkinson's Disease Awareness Month. In Canada, more than 110,000 people are living with Parkinson's disease, and the prevalence has doubled in the last 25 years. Despite the growing prevalence, movement disorders like Parkinson's remain some of the most challenging to diagnose and to treat. I'm thrilled today to be joined by 2 exceptional medical leaders who have dedicated their lives and their careers to movement disorders. Dr. Anthony Lang and Dr. Lorraine Kalia. Dr. Anthony Lang is the director of the Movement Disorders Program at UHN, which includes the Edmund J. Safra Program in Parkinson's disease, the Morton and Gloria Shulman Movement Disorders Clinic, and the Rossi Progressive Supranuclear Palsy Center. Dr. Lang holds the Lily Safra Chair in Movement Disorders at UHN, as well as the Jack Clark Chair for Parkinson's Disease Research at the University of Toronto. He completed his training at the University of Toronto, as well as King's College Hospital and the Institute of Psychiatry in London, England. As a result of his work and his leadership in the field, Dr. Lang was appointed Officer of the Order of Canada in 2010. He was also the recipient of the King Charles III Coronation Medal in 2024. This is an award given by the Governor-General of Canada to someone who has made a significant contribution to our country. Dr. Lorraine Kalia is a senior scientist at the Krembil Brain Institute and a neurologist at Toronto Western Hospital, specializing in Parkinson's disease and movement disorders. She holds the Wolfond Krembil Chair in Parkinson's disease research. Dr. Kalia is also an associate professor and staff researcher at the Tan Center for Research in Neurodegenerative Diseases at the University of Toronto. She completed her training at Queen's University, the University of Toronto, and Harvard University. Through her research, Dr. Kalia seeks to understand the molecular processes behind Parkinson's disease to develop novel therapies by targeting these pathways. Dr. Lang and Dr. Kalia, thank you so much for joining us today. I want to remind our audience that you can find at the bottom of your screen a Slido link. And please do vote on the questions that you would like most answered today by our 2 great doctors. So thank you so much for joining us today. It is Parkinson's Awareness Month. And what would you like our viewers, our audience, to know about Parkinson's disease? Maybe Dr. Lang, you'd like to kick us off.
Sure. So Parkinson's disease is what we call a neurodegenerative disease, a brain degeneration. It's the second commonest after Alzheimer's disease. And you pointed out how common it really is and how the frequency is increasing. And that becomes a major challenge. It's a challenge to understand why it is increasing, but it's particularly a challenge in helping patients who have a progressive neurological disease for which we don't have a cure right now. And hopefully we'll be talking about developments that'll maybe get us there eventually.
Dr. Kalia?
Yeah, I just highlight what you actually mentioned in your introduction, which is the increasing prevalence of Parkinson's disease, I think is an important thing for listeners to know. For many people, they might have not been touched by Parkinson's disease, haven't known anyone with it, but I think increasingly so, people are starting to see a parent who's developing Parkinson's disease, a coworker who's developing Parkinson's disease, and in part because it's more prevalent, in part because we're probably diagnosing it better, and it's not a disease that is so much hidden or uncommon or rare. It's a disease that I think is going to touch many of our lives increasingly over time, and without actual treatments that can stop it in its tracks, a disease that people live with for the rest of their lives once they're diagnosed with it. It becomes a real challenge for the individual with Parkinson's, for their family, and for people trying to treat and allow people to live their best lives.
Why do you think that the prevalence is increasing?
I think it's fair to say that there's a multitude of reasons that are causing its prevalence to increase, but the major reason is that we're living longer. And so heart disease and cancer and all of these diseases where there's been huge strides that we've made in being able to allow people to live through their heart attacks, live through their cancer. Neurodegenerative diseases tend to be diseases of aging, things that happen on our later decades of life when we're 60, 70, and 80. And if you don't live until you're 60, you're never going to see that you had this neurodegenerative disease. Whereas now when people are actually allowed to live longer lives, now we're starting to see these neurodegenerative diseases become more prevalent. I think we're probably diagnosing it better. There's probably capabilities amongst specialized neurologists to be able to do that better, and the recognition that if somebody moves a little bit slower and has a little bit of shaking, sometimes people attribute that to, oh, that's just getting old. I think there's increasing awareness now that that's not necessarily just getting old, and there's a disease underneath that, and so we're able to actually give people that diagnosis. I think there's other contributors that many of our colleagues are also purporting are important contributors, which are pollutants and things that we could potentially change in our environment. I wouldn't say that's the only contributor. Aging is the major contributor, but there's many different pieces, I think, that are adding to the increased number of people with Parkinson's disease.
So we haven't figured out how to stop aging at this point. I would love, Dr. Lang, if you could come up with some way of doing that.
I'm trying to do it myself and not doing a very good job of it.
What can we do as individuals and as patients to potentially prevent movement disorders or slow down the impact?
Well, I think the biggest challenge is we don't know the cause, and as Lorraine has pointed out, age plays a huge role. So we're not going to get rid of aging, as you've pointed out, and until we have a much better understanding of cause, we can't eliminate the causes in the environment or wherever else. We know that a proportion of patients, probably around 15%, have what are called monogenetic forms of Parkinson's, where single genes contribute. We also know that your overall genetic makeup plays a role as well. So we now speak about what's called the polygenic risk component. So a combination of multiple genes all adding up to contribute to your risk of developing Parkinson's. And so we know that's actually very important as well. Environment, as Lorraine has indicated, probably does play a role. There are certain pollutants, certain pesticides, certain things like trichloroethylene that probably do contribute, but probably not the main reason for the increasing prevalence of the disease, which is, as she said, most likely aging. I think as with all health-related things, living healthily, if that's the appropriate term, living a healthy lifestyle, Mediterranean diet, exercise very clearly, if not preventing or delaying, at least if you're healthy and fit, you tolerate the ravages of Parkinson's and other neurodegenerative diseases better. So I think what you can do is a healthy lifestyle, managing things like diabetes, hypertension, other things that add to it. Because when a patient dies with Parkinson's disease, and when we look at the brain under the microscope, we often find it's not just Parkinson's disease that's in their brain. It's strokes and a variety of other things. So it's a combination of pathologies. And so if you can limit some of those other pathologies, like controlling your diabetes and getting less strokes, that's going to have an impact as well.
So the environment, there's genetics, eating well, exercising a lot. That sounds like a great way to slow down aging as well.
Yeah, very much so.
And is the prevalence increasing around the world at the same rate?
Yes, although there's some populations that you see aging increasing to a greater extent. So certain third world countries where the quality of life is improving, and so where the age of death might have been on average 50, it might now be 70 or something like that. So in those populations, the prevalence is increasing even further, probably because people are living longer, to the point that in North America they would have developed Parkinson's previously.
Now, Dr. Kalia, you mentioned improvements in diagnostics. Can you help us understand how we were diagnosing, let's say, 40, 50 years ago and today? How has that progressed?
So it hasn't changed very much. The way that diagnosis is typically done is actually by a neurologist. So we rely on what we call clinical findings. And that's what we see when a person comes to our clinic. We take a history, get an understanding of when their symptoms started, how they've progressed. We do a physical examination to see how different parts of their nervous system are working, how they're moving, how they're walking. Sometimes what also helps us is how things progress over time. Did they respond well to a medication that we expect them to respond well to in Parkinson's disease? And all of these pieces of data, basically, give us the information to be able to diagnose somebody with Parkinson's disease with relative accuracy over time. There is a shift that's happening currently as a consequence of research and our understanding of what contributes to Parkinson's disease and what are markers in the brain of Parkinson's disease. And these are what we call biomarkers, or markers from biological samples such as cerebrospinal fluid or spinal fluid when you get a spinal tap, hopefully increasingly from blood, and also advances in brain imaging that I think in the very, very short term are going to actually make a difference in terms of the way that we diagnose Parkinson's disease. So it won't simply be, I see these things in you, I think you have Parkinson's disease, let's see how things evolve over the next couple of years and I'll have a clear understanding. That we'll actually have more definitive tests to be able to do, to be able to say, yeah, I think, to give us more certainty in terms of the diagnosis.
And do you think that we are coming close? Maybe Dr. Lang, you want to
Yeah,
help
I
us
was going to
understand?
say that as with all neurodegenerative diseases, we now recognize that the damage has already started decades before the patient comes to us as a neurologist and we can feel comfortable making a clinical diagnosis. So the biology, the abnormalities are present, they're progressing. We have a threshold before we develop symptoms. So in Alzheimer's disease, you can have considerable damage to your brain before you have any cognitive disturbance. In Parkinson's, you can have loss of the principal chemical in the brain that we talk about, dopamine. You can be down by 50, 60% and still not have any symptoms of Parkinson's. So we know the biology is present, and we're now moving towards recognizing that we need a biological way of approaching the disease, not just waiting for the clinical signs to develop. If we're ever going to have successful disease-modifying therapy, if we're ever going to be able to shut down the progression, we believe that we have to institute that treatment at the earliest stages as possible. And so the analogy is always closing the barn door after the horse is bolted. You don't want to close the barn door and introduce therapy when the ravages of the disease are already widely present in the brain. So we're now moving towards a biological approach to defining the disease so that we can introduce the treatment at the earliest stages.
Do you think that in our lifetime we will see a blood test, for example, to diagnose Parkinson's?
Definitely. Yeah. I'm willing to say in the next 5 years.
Wow.
Yeah.
That's quite ambitious. And so why do you believe in the next 5 years we're going to have a blood test?
Because of the advances that are being made so rapidly currently in the realm of biomarkers. I mean, it's exponential. I'd say if we had this conversation 10 years ago, people were starting to test biological fluids and finding some signals, testing it in small populations, maybe seeing some differences. I think the studies now are much larger. There are clearly tests that can help to differentiate between people who have Parkinson's and who are healthy. One of the challenges is being able to diagnose Parkinson's from individuals who have other neurological diseases. That is still a major challenge that needs to be overcome. But in addition to the technological advances to be able to measure abnormal proteins in, for example, spinal fluid, it's being advanced into blood. And I think just seeing what's been happening in Alzheimer's disease, where we tend to be a couple steps behind, not too far behind, but a couple steps behind. I think lots of the learnings that have come from Alzheimer's disease are easily going to be translated into Parkinson's disease.
Yeah. Neurodegenerative diseases now are classified on the basis of the aggregation and deposition of certain proteins in the brain. And each disease is hallmarked by a specific protein or a combination of proteins. Alzheimer's, there are two proteins, beta amyloid and tau. And Parkinson's, the main protein is called alpha-synuclein. And we now have the ability to define the presence of the abnormal alpha-synuclein in spinal fluid with a 90% sensitivity and specificity. In skin, roughly the same, and the expectation that in blood, and there are already preliminary studies showing blood tests for alpha-synuclein being very positive. So I think the technology, I'd bet it's less than 5 years.
More optimistic.
Dr. Lang, how has treatment changed since you've started in this field?
Well, the commonest treatment that we use in Parkinson's disease replaces the deficient dopamine. It's a precursor of dopamine or a prodrug called levodopa. Many people have heard of levodopa. Levodopa is taken by the body, converted to dopamine, and you increase your dopamine levels. That was introduced in the late 1960s by a man by the name of Kotzias in New York State. And he introduced high doses of levodopa. Previously, it had been played with and tested, but it had been given up. People didn't feel it was effective. He showed that it was in the higher doses, and that really has become the standard. And it is truly a miraculous response that patients have when we replace the dopamine. And it remains the touchstone, the best treatment that we have. Despite multiple other drugs being developed, this still remains the best treatment that we have. Remarkably, I think most of us expected better treatments to come along, but they haven't. There are problems with it, though. First is that everything in Parkinson's isn't dopamine. The disease spreads to other regions of the brain that have little or nothing to do with dopamine, so replacing dopamine isn't going to provide benefit to those, and we can talk about some of those later. Further, levodopa is a very short-acting drug. When you first start it, the brain seems to have the ability to store it and release it more physiologically. But with time, the body's response is linked to what's happening in the blood, and it goes up and down multiple times a day. What we call the half-life of the drug is only 90 minutes. And so as the patient has longer standing Parkinson's and been treated for a longer period of time, they go from on when the drug is working to off when the drug is not working or is worn out several times a day. Oh, wow. So we need better treatments to smooth that kind of response out. And there are longer acting forms of levodopa that are being developed. They've not really been what we had hoped, but some better versions are coming along. And this is where the surgery for Parkinson's really has revolutionized the management.
Before we get into surgery, Dr. Kalia, did you want to add anything on the medication?
I did, actually. And so levodopa is tremendous, and we can see major changes in people's lives, quality of life because of it. I think one thing that we always point out to people when we start them on levodopa is one of the caveats around it too is it's replacing a brain chemical that is made by cells in the brain that are dying over time. So it doesn't stop those brain cells from dying. It doesn't save those brain cells or regenerate any brain cells. In many ways, we're basically chasing our tails because the brain cells are dying and we're giving back the dopamine. And so what we miss and what we don't have currently are these disease-modifying therapies, which can actually, in some way, either slow the death of those brain cells, in the ideal scenario, stop the death or prevent the death of those brain cells. And that's a major unmet need in Parkinson's disease.
Every patient and their family wants to see a cure. And so, Dr. Kalia, are there any research projects done here at UHN or anywhere around the world that could give us hope?
For sure. I mean, I think research is hope. I think the research being done in Parkinson's disease is hope, and I think half the conversations I have with many of the patients who come to my clinic are around what research is being done, because I think that gives them hope. And there are many buckets of types of research that are being done, some in terms of areas to try and better diagnose it earlier, and then there's definitely areas of research that are trying to find either these disease-modifying therapies or, I guess in the very kind of boldest sense of the word, cures. And to do that, we have to understand why brain cells are dying more quickly than normal in Parkinson's disease. And we have made huge advances with that. I mean, I think locally we understand the disease a lot better around how alpha-synuclein is associated with neurodegeneration, how it contributes to it, and ways that we could actually try and prevent what alpha-synuclein does in brain cells in a way to try and prevent brain cells from dying as a consequence of this protein alpha-synuclein. And I think there are many different strategies that are being taken, and we need that. We need many different. We need many different eggs in many different baskets to be able to hopefully at least find one or two useful therapies.
Now, is that your research that you're working on?
Yeah, and so some of the research that we do, a major focus is to try and find these kinds of disease-modifying therapies, and we have used a couple of different strategies. One where we try and repurpose old drugs or drugs that are used for other indications to try and find a bit of a quick fix to Parkinson's disease. So if we can find a medication that's been used for another indication, it's safe, it's been used in humans for decades, for example, and then we can actually show that it has benefits in Parkinson's disease, we could potentially quickly bring that to a clinical trial. So that's one approach that we're doing. Another is just brand new science, trying to find new targets and developing new therapies off of that. That's obviously a slower road, a more challenging road, I'd have to say, in terms of funding and getting it from the bench to the bedside or from the lab into the clinic. But that's, I think, an area where we're going to find like really new novel therapies.
Can I make a couple of additional points? The first is that Parkinson's is a very heterogeneous disorder, and it's probably actually better to think of Parkinson's diseases. It's probably several diseases, so to think that a single drug or a single approach is going to cure everybody with the disease is probably naive, or is definitely naive. I'll give you an example. Cystic fibrosis is a disease where there are remarkable curative treatments that are effective for 5% of the people with cystic fibrosis that have certain characteristics, certain biological characteristics that allow you to predict this is somebody who's going to respond to this treatment. So it's likely we're going to be dealing with the same kind of thing in Parkinson's disease, multiple different disorders that will be biologically characterized before you initiate the treatment. And then the treatment is probably going to have to be combination therapies like we use in cancer. So mixtures of therapies that attack different components of the processes that Dr. Kalia is working on in the lab.
And how do you know which molecule to use on which patient?
We don't yet, that's the point. That will come.
Dr. Lang, can you tell us a little bit about the surgery option? What does that mean for patients?
Yes, the commonest surgery for Parkinson's is very old. Surgery was used in the 50s, for 1950s, where surgeons would what we call lesion certain parts of the brain, damage areas of the brain that they believed were overactive. And it was quite effective, particularly for tremors. So a proportion of patients, a reasonable number of patients with Parkinson's have a tremor, and when it becomes disabling, we've been, since the 50s, managing that quite effectively with surgery. When levodopa was introduced, the need for surgery declined tremendously. I have a cartoon of a neurosurgeon sitting outside his barber shop with a little sign saying 25 cents for the whole works, because he had nothing else to do. He was no longer operating on patients with Parkinson's disease. But then it was recognized that the complications of levodopa plagued our patients with the ups and downs and the abnormal movements that many people have seen in Michael J. Fox on television. And so those are the type of patients who continue to respond very well to levodopa, but whose response is complicated by these variations and fluctuations, who respond the best to the surgery that we have now. And the surgery we have now is called deep brain stimulation, where a neurosurgeon implants electrodes or wires into the brain. We concentrate on two regions of the brain. One is called the subthalamic nucleus, or the STN, and the other is the globus pallidus interna, or GPI. The STN, GPI, different targets, but various different reasons for using one or the other, but they're both very effective. And so the surgeon implants the electrodes. The electrodes are attached to a pacemaker that is implanted under the skin, usually just under the clavicle here. And then the neurologist, who's the expert in the programming, expends a tremendous effort changing the programming, the electrical current and the various aspects of that current and the locations along the tracks of the electrodes, and changing the drugs as well, because remember, we've got a varying playing field here with drugs and electrical current, and so the neurologist has to be really expert at choosing what to do with both of those. And the best outcomes are really quite remarkable.
Tell us about those outcomes. Does it stop the progression of the disease?
No, I think that's really important. The surgery does not provide anything that levodopa doesn't provide, with the exception of that much smoother course, the amelioration of the fluctuations and those abnormal involuntary movements. It doesn't change the natural history. Many patients over the course of time, I mentioned, develop things that don't respond as well to levodopa or don't respond at all. Good examples are ambulatory difficulties, walking troubles, what we call freezing of walking, and falls, postural instability and falls, swallowing and speech difficulties, difficulties with what's called the autonomic nervous system, control of the blood pressure, the bladder, things like that, and then most importantly, cognitive function. And unfortunately, a proportion of Parkinson's disease patients develop cognitive difficulties and eventually dementia. And the deep brain stimulation does nothing for the natural history of any of those things. And in fact, there's a worry that sometimes cognitive difficulties can occur as a consequence or worsened by the deep brain stimulation, because you're operating on a brain. You're potentially adding a little bit of damage to the brain. So the surgeons and the neurologists doing this are really quite concerned, and neuropsychological tests are a very important component of predicting who should be operated on and who shouldn't be operated on. And so if a patient has very significant cognitive difficulties to begin with, they may not be a candidate for the surgery.
What are the advantages then of doing the surgery?
Well, again, if you have a relatively young, otherwise healthy individual with these profound fluctuations in a daily life that you can't rely on and can't trust, you don't know whether you're going to be mobile enough to get up and go to the bathroom or go out and have dinner with friends or whatever, you regain a normalcy to your life that you didn't have before. So it really is quite a fantastic response, one that we hope eventually we'll get with medication if we can provide that more smoothly. And in fact, there are methods of providing levodopa by pumps now, using it through the duodenum, and what's called an enteral infusion of levodopa with a pump into the gastrointestinal tract where it's absorbed on a nice even basis, and now transdermal, a form of levodopa can be given by a pump the same as insulin can be given by a pump.
And these treatments, Dr. Kalia, that we've just talked about, the surgery and the different ways of providing the medication, is that considered standard of care, and is that available around the world?
It is standard of care for certain. I think as we discussed prior to this, sometimes people come into our clinic and are curious about this experimental therapy called deep brain stimulation, or are maybe frightened when we mention deep brain stimulation because they think it's an experimental therapy, and it's standard of care. It's standard of care at our center. It is available around the world, not as easily available in every country, but in the Western world it's very easily available. I think we're one of the major centers in North America that does deep brain stimulation, and so in terms of number of cases that are done, a large number and a large experience here, which is important because, I mean, as you just heard, not everybody with Parkinson's disease is a good candidate for deep brain stimulation. There are complications that can happen if you choose the wrong person for deep brain stimulation, with concerns around cognitive function and worsening of that. And so there's a whole team that evaluates patients here to make sure that we're picking the people who are going to actually do well from deep brain stimulation. And I think that's in part why we see really good outcomes.
If we can diagnose earlier on in the disease progression, would the patients do better longer?
At this point, maybe preparing them for what's to come, healthy lifestyle, all the rest that we've talked about before, possibly. I think the expectation is that if we can make the diagnosis earlier and they can enroll in trials of treatments that might slow the progression, and again, the earlier they can be enrolled, hopefully the more likely it is that we're going to see an effect. So I think that in broadest sense, that would be the best way of thinking about it.
Yeah, I think they're running parallel, right? Like, we need research to be able to diagnose earlier, but that can't live by itself without us actually having a research to actually have therapies to give to people when we diagnose them earlier. And you know, they're running in parallel tracks. At certain points in time, one area of research, I think, moves ahead of the other, but ultimately we need successes in both.
So to many people in our audience today, research can sound scary and disconnected from the hospital. Perhaps, Dr. Lang, you can kick us off. Can you help us understand what it means to have research in an institution like UHN, and what does that actually mean to our patients?
Without research, we're not going to do anything better than we're doing now. So we're stagnant. And if a patient comes to us and in a frustrating fashion says, well, you can't prevent my disease from getting any worse, and then they don't want to participate in research, that's sort of counterintuitive and counterproductive. I think it's impossible for the field to move forward, and it's impossible for us to see a change in the suffering that this and like diseases cause without advances in research, and without patient participation in research, we're not going to get there.
Dr. Kalia, should patients be concerned or afraid of joining a clinical trial?
I think that patients should be given the option. I think that clinical trials and research are really a continuum of care. I think it's, you know, we offer diagnosis, we offer treatment, but we have to offer research to patients as well. It's part of care. Patients need to evaluate what they're hoping to accomplish from research, what they're hoping to get out of it, where they are in terms of their life, commitments that they can make, and then be informed in terms of what clinical trials there are, and does it meet their goals. Should people be frightened of clinical trials? I don't think they should be frightened of them. They should be informed about them. If there's aspects that frighten them, then maybe that's not the clinical trial for them. But I think that we have an excellent infrastructure for doing clinical research. Of course, everything's reviewed by our research ethics board, and in our own clinic, we bring on clinical trials that we think are important to be able to offer to patients, to be able to have disease-modifying clinical trials for people who want to venture into that space, having clinical trials that actually look at different ways to make levodopa better, or different types of levodopa to make it last longer, and then even in the DBS space, having clinical trials that try and optimize and make better what we're doing already with DBS.
Yeah, research comes in all shapes and sizes, doesn't it? So you can have research that is just filling out a questionnaire and providing us information about what you're experiencing or about your disease, all the way through to the most experimental surgical therapy that could have substantial risk. And you'd be crazy not to be afraid of that. But again, when informed and when the treatment is appropriate, and if you feel that you're a good candidate, then participate. It's really important that patients understand they're part of the team. We're not doing this for us. We're doing it because we're dedicated to getting beyond where we are now. We don't want to be stagnant. We don't want to be sitting still. We want to see a change in the natural history of this disease that I've seen far too often in hundreds of patients over many years. I'm gray for a variety of reasons, but one of them is the long time that I've been doing this. And the second is my son, but that's beside the point. No, I think what we really want to do is change the course of an illness that affects our patients and families. And the way we do that is in concert with the patients. We have to be a team working together.
So let's talk about the team. UHN is the #1 hospital in the country, but when it comes to Parkinson's diseases, do we have a good team? Do we have we done some research that is recognized? How do we explain to our patients how good or not UHN is in Parkinson's disease? Who would like to kick us off?
Okay. She's laughing because I'm the one that built the team. And without sounding like I'm tooting our horn, we are one of, if not the best in the world. People know about the Toronto group. We are the Toronto program. We have people that do everything related to Parkinson's disease, from the basic biology, working on cells, all the way through to the epidemiology and the genetics, through to understanding the imaging, through to understanding the physiology, through to understanding the pharmacology, et cetera, et cetera, et cetera. And then the later stage advanced therapies, including surgery. There really are not any programs, I believe, in the world that do everything at the level that we do. And I'm not just saying that because that makes me feel good, but it does make me feel good. It's because we're told that regularly. Patients go down to the Mayo Clinic and they say, well, you're from Toronto, why are you here? You got UHN group. I mean, we hear this time and time and time again, and it confirms what we do, why we do it, what we feel about what we're doing, and how proud we are about what we're doing. And so I think we're pretty good at what we do.
And what is the role, Dr. Kelly, of philanthropy in the work that you do and the team's work?
It's so important. I mean, I can talk personally about my own, building my own research program and the role that philanthropy played at every stage, actually. So there was an anonymous donor, a grateful patient when I first started, who provided startup funds for my laboratory. And startup funds are literally that. I mean, it's to start you up. It's to buy equipment. It's to hire that first person in the lab. And that was philanthropy that did that. Philanthropy was also really important when there were other centers in the country that were trying to recruit me away. And it was important in terms of philanthropy that came forward, donors that came forward to actually help bolster the research that we were doing at that point in time. And right now, philanthropy is remarkably important in terms of trying to take what we've developed in the laboratory and try and move it to the clinic. That's area of research that typical funding agencies, CIHR, they're not particularly excited about the kind of bread and butter, just translational work. They're excited about the new discoveries. But if you have a new discovery, but you need to tweak it, you need to be able to make it so that you can actually deliver it to human beings as opposed to animal models. That's less exciting research, and philanthropy is really important around that as well.
Dr. Lang, philanthropy has always been powerful for big, bold ideas. Do you have any big, bold ideas that you're looking for support for?
Always. The early diagnosis, we're involved in a number of studies looking at ways of establishing effective biomarkers. a very large program for that. One of the things that we're particularly interested in is something I mentioned before, that heterogeneity of the disease and understanding why it's so variable, why some people get certain aspects. And we're looking at different characteristics in the brain. One of the things that unfortunately we don't have easy access to is brain tissue. And we can't do a lot of the work that we're doing without access to brain tissue. This isn't a liver disease or a kidney disease. I can't take a little bit of your brain easily and study it, study the molecular state, study the proteins, etc. And so brain donations are very, very important to neurodegenerative diseases. And we have a very active brain donation program with an outstanding researcher who directs that program, Dr. Kovacs. And some of the work that we're doing in collaboration with his laboratories really is very important, and trying to help understand this heterogeneity. And if we can understand it, then maybe directing the specific treatment to the specific individual to maybe cure that 5% to begin with. And I think we're going to have to crawl before we can walk, before we can run in this area.
Are you using artificial intelligence in any way in your work?
For sure. I mean, I think artificial intelligence has permeated so much of science in general. It's amazing how much has progressed. I think 5 years ago we started on an AI project where we were trying to screen for drugs in a collaboration with IBM. And if you look at the actual AI platform that was used just 5 years ago, it's infantile, I think, in comparison to what is being used now. But there are so many aspects in terms of the way that we look at cells under a microscope that has AI infused into it. Students refining their writing, I mean, are using AI to clean up their actual written products, and looking at how proteins fold, how actual drugs might bind to proteins. That's all AI. It's actually everyday AI. Even places where maybe it's a little bit more invisible than you realize, it's there.
Yeah, the amount of data that is now being collected in various studies, for example, some of the brain studies looking at different proteins, hundreds and hundreds of proteins in all permutations and combinations that you could never be able to calculate in your own head. So trying to understand how they interact and relate, it really requires AI to be able to analyze.
We have a question from Barbara of what is the probability of a child whose parent and grandparent have Parkinson's disease? What is the probability of that child carrying the gene?
So with a family history, nowadays we do genetic studies. So this is standard evaluation of patients like this who have a positive family history. Now, not somebody who comes to us asymptomatically. Generally, somebody coming with Parkinson's, then we define a gene, but eventually, I think asymptomatic individuals, when we have treatments that can be useful for that individual. Not much of a point to tell somebody you got a gene and then I don't have anything I can do about it, although you could argue that helps them plan their future, and I think there are reasonable justifications for doing genetics in someone with a clearly strong family history. But we'll do genetic testing and define whether they have one of the known genes. I mentioned the mixture of genes, though, that polygenic risk. That's not standard yet, but probably will become standard in the next few years. And so we will be able to tell that individual what the risk is over time.
Can you please tell us about the connection between Parkinson's and REM sleep disorder? Does anyone want to take that one?
Yeah, for sure. And I think we've been half alluding to it throughout our conversation today. So REM sleep behavior disorder, for those who don't know, it's a sleep condition. When we all fall asleep and have dreams, our body is typically paralyzed. There's a switch that gets turned off so that you actually don't act out your dreams. But in REM sleep behavior disorder, that doesn't happen. And so when somebody is dreaming that they're fighting off an intruder, they're actually punching. When they think that they're trying to run away, their legs are moving. And so it's usually a bed partner who realizes that their person beside them is flailing. And so that is REM sleep behavior disorder. We call it isolated or idiopathic when it occurs by itself. And much of the work that has been done, I'd say over the past decade, 2 decades now, there was a a link that had been established between REM sleep behavior disorder and Parkinson's disease, suggesting that maybe REM sleep behavior disorder was somehow associated. I think the work of by following people who had REM sleep behavior disorder over the past several decades has made it clear that in a large proportion of people, up to 80% of people who have REM sleep behavior disorder, that is actually early Parkinson's disease. And so over time, for some people, it could be a decade later. For some people, it could be 2 decades later. That person will develop Parkinson's disease. And why that becomes important is what we were talking about, is if we actually are able to say these people have the various earliest stages of Parkinson's disease, and we have a treatment that can slow down the progression, then we could actually treat people with a drug, and they would never develop the movement problems that we use to diagnose Parkinson's disease right now.
And I imagine this is different from sleepwalking, which we see very frequently in children.
Yeah, yeah.
Okay, just to reduce the panic
Yes.
from our audience.
Totally different.
Yes.
Yeah, so sleepwalking doesn't happen in REM sleep where we dream. It's in a different stage of sleep, and you're right, it occurs in children most often.
Yes.
I should just come back to one of the points we made earlier. Remember I said that the disease is present in the brain for sometimes decades before. Well, REM behavior disorder is what we call a prodromal or premotor manifestation. And there may be others like anxiety and panic attacks, depression, constipation, loss of the sense of smell. All of these may predate the development of your little tremor or slowness by many years.
Please comment on the frequency, timing, and possible prevention of Parkinson's-associated dementia.
That's a tough one. The answer is variable. Like I was saying earlier, this is a very heterogeneous disorder. Some people will develop dementia relatively early on. This tends to occur more commonly in elderly individuals who develop Parkinson's disease. And we now recognize there are often mixtures of diseases, as we were mentioning before. So Alzheimer's disease is more common in Parkinson's disease than not Parkinson's. So there is a link, and a proportion of patients that develop dementia will have a combination of Alzheimer's disease and Parkinson's. However, you can dement with Parkinson's alone, and this may be an early manifestation in some and a very late manifestation in others, and in still others it may not occur at all. And so it's quite a variable feast, and this is where the heterogeneity comes in. This is the understanding of who is it that develops this early. So for example, the people that have REM behavior disorder early can have dementia earlier. So there seems to be a link between REM behavior disorder and early cognitive changes. So there are clues. We just don't have all of the information that are going to predict who's going to develop it when, and obviously the most important thing is what can we do to prevent it, and we don't have that yet.
Yeah, and I think importantly, it's not a feature of the disease that responds to dopamine. So whereas there's many symptoms that we can improve with dopamine, especially with relation to mobility, it's not a symptom that we have this levodopa that we just talked about was so helpful. It's not a therapy for that.
Part of the cognitive difficulties relate, not all, unfortunately, relate to a reduction in another chemical in the brain called acetylcholine. And we do have drugs that replace the acetylcholine or increase the acetylcholine in the brain, and they're modestly effective in some, but they're not the answer.
We have a lot of family members and caregivers who are with us today. Dr. Kalia, what would you suggest that they be on the lookout for?
In terms of their loved ones?
Their loved ones.
I mean, I think one thing that I like to tell caregivers and people with Parkinson's is, I think, again, something that we've already discussed and alluded to, is that their course is going to be their individual course. Sometimes people sit in our waiting room and worry about what they might see in terms of how other people present and what the features are that that they're dealing with. And same with caregivers. They might know somebody who has Parkinson's disease and worry that that's the fate that they're going to have to face. But I think it's important for them to know that their course is very individual, and how their loved one's going to experience the disease can be very different. Their response to medication, what symptoms they have, what symptoms don't develop over the course of their disease. And so I think it's not that they need to keep a close eye and a close watch, but I think they just have to just try and appreciate that what they see in their loved one can be related to Parkinson's. It might not be related to Parkinson's, and that what they see in their loved one might not necessarily reflect what they've seen in others or what they've read about.
Dr. Lang?
One of the points that Lorraine mentions is really important, that we see a lot of patients, so you may be addressing individuals that we're caring for, and it's really important for people to know that not everybody that is seen in a movement disorders clinic has Parkinson's disease. Yeah. Some of the more severely disabled patients we see have Parkinson-like disorders, like progressive supranuclear palsy, for example. You mentioned the Rossi program that is supported by a very, very generous donation. Hopefully we're going to get some answers for that terrible disease, but it's not Parkinson's. And so when you see a patient that's very severely debilitated in the waiting room, they may not have what you've got. And that's really important to reassure some patients, especially when we're first diagnosing them at the earliest stages of the disease.
What is the role of MRI imaging in the diagnosis of Parkinson's?
It helps exclude other conditions very effectively in some. So some of the other Parkinsonian disorders have very hallmarked abnormalities on the MRI scan that differentiate Parkinson's disease from these other conditions. We have a way of looking at the dopamine area of the brain now with MRI scan that tells us in a non-specific manner you have a degeneration in that region. So it's not Parkinson's, it could be progressive supranuclear palsy, it could be multiple system atrophy, another Parkinson-like disorder, but you have a degeneration in your dopamine system. And there is another scan that is available but not funded in Ontario called the dopamine transporter SPECT scan. We can look at dopamine more effectively with that, but this other method with MRI is almost as good. And we're finding this very useful, and Toronto Western Hospital has a very good program for that right now. We are working on other ways of using MRI to help differentiate, but they're still experimental, and using AI to try to differentiate the volume changes in various regions of the brain in Parkinson's versus other conditions.
We have a question here about what are some of the early warning signs that people often misinterpret as Parkinson's disease?
That they think are Parkinson's disease? I'd say tremor is probably a common one, in terms of thinking that every tremor is a Parkinson's disease tremor. And so sometimes we'll see people who have essential tremor, or even something like we call a physiologic tremor. If I drink enough coffee, I'll give myself a tremor, and sometimes that can make people nervous that they think they have Parkinson's disease. I'd say that's a major one. Sometimes people, I think, also come with some walking problems that they think might be reflective of Parkinson's disease as well, and maybe it's actually more arthritic problems or low back problems. I think there are certain aspects around Parkinson's disease and what you see and what you read about that can be quite nonspecific, which I think why there's a value of seeing a specialist to be able to we look for all of the pieces, right? We don't look at one single symptom individually. We're looking for all of the pieces to kind of check off the boxes to say, yeah, this fits what we call a syndrome or a constellation of symptoms that fit with Parkinson's disease.
Dr. Lang, you've been at UHN for a long time. What has kept you here?
I love what I do. I love the people that I work with. I love the patients that I deal with. I enjoy interacting with people. Patients with Parkinson's disease and diseases like that are nice people. I mean, in general, people are nice. Maybe not, well, I won't even say that now, but I think it's the community of people I work with and the collaborations that we've established. So it's a mixture of everything, but I enjoy getting up in the morning. I look forward to coming to work. I look forward to what I do, and I'm stimulated as much now as I ever was.
We want to leave our audience with some hope. And so I'm going to ask both of you to let us know, share with us what What inspires you, and what brings you hope for the future? Dr. Kalia?
So there's lots of things that inspire me around Parkinson's disease. I think we're at a really important, critical time where our knowledge around the disease is exponentially increasing. I think we're coming closer to being able to diagnose it better, and I think with that we're going to be able to treat it better. What really inspires me, though, are the patients that I see in the clinic. I think they're so inspirational in terms of walking through life with this condition. They're empowered, more so now than before. They're engaged. They want to learn more about the condition. They want to contribute to research. They want to teach me, which I think is an amazing, amazing inspirational aspect around Parkinson's disease right now.
Dr. Lang?
I really think we're going to see a change in the natural history of the disease. And I really want to see that. I want to see it for all of the diseases I deal with. And the pendulum has started to move. The needle has shifted ever so slightly, but definitely in Alzheimer's disease. So the first treatments that are attacking the proteins that are depositing in Alzheimer's are showing us a signal we never saw before. And this is after a lot of failures. So we're talking about trials and research. You have to fail many times before you're going to succeed. You have to learn from those failures, though. So they're really not failures. They are maybe a negative trial or a negative study, but the fact that you've learned and moved on, taking advantage of what you've learned, is really critical. And I think we're seeing that in the neurodegenerative field, and I think we're going to see it in Parkinson's, I hope, in the not too distant future.
They're lessons, right? They're lessons.
Yeah.
Dr. Kalia, Dr. Lang, thank you so much for joining us today. You've certainly inspired me, and our community continues to inspire us at UHN Foundation. Philanthropy makes the difference between quality and excellence. And when it comes to our family members, to our loved ones, to our community, everybody wants to see the very best doctors in the world to care for their loved ones. And the only way to make sure that we have access as a community to the very best clinical leaders like Dr. Lang and Dr. Kalia is that we support their big dreams, their big, bold ideas that hopefully will lead to better diagnostics and cures. So I want to thank all of you for joining us for this conversation today. Hope you will join us again for the next Behind the Scenes. Please be on the lookout for the invitation, and have a wonderful evening.